Welcome to Derms on Drugs, a video podcast brought to you by scholars in medicine. Derms on Drugs is where cutting-edge derm meets low-grade to mediocre comedy. I'm Matt Cyrus, and each week I'm joined by my residency buddies Laura Ferris and Tim Patton, where we use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology, everything you need to know to be on the cutting edge of derm, and it'll be the most fun you've ever had while actually learning something useful. Tune in every Friday and visit us at Scholars in Medicine, Spotify, and Apple Podcasts. So let's go ahead and get into it. We've got a special episode this week, so we're going to cover 6 articles that we thought were the most interesting in the literature in the recent weeks. And we are going to start off by jumping right into Dr. Ferris with our first article. Dr. Ferris, take it away.
All right. So the paper that I have is in JID Innovations, and it is, I'm going to totally butcher the name, Maglakides et al. But this is surgical debulking modifies notch signaling and may improve Vismodegib effectiveness for locally advanced basal cell carcinoma. So
Ferris,
this is not a huge study.
Wait, for just a second there, I was like, when you're like, I'm going to butcher this, I'm like, it's surgical. The first word is surgical. Like, how are you going to, what the hell is wrong with you? Okay.
I could do that.
Okay.
Yeah. So basically, this was 4 patients. So this is sort of a small proof of concept. But these are patients who had locally advanced basal cell. And, that's a term that gets thrown around a lot since we got drugs approved for it. What's locally advanced? And it's like, I don't know if it's like half your ALA is that locally advanced. I mean, these are like locally advanced. These are big tumors if you look at, in the paper. So like 5, 6, 9 centimeters. Okay.
Like if you've watched the show The Last of Us, is that the one with the fungus that comes out of people? That is what this woman's back looks like.
That's I thought the same exact thing.
It is just, it's a fungating lesion.
I do not watch TV like you two do, so I will take it at your.
We're not running a department. We're not running a department.
Yeah, that's right. We're not chairs. Like fair.
Exactly. So. Yeah, so 4 patients, locally advanced basal cell, debulking, then Vismodegib. So after their debulking, they got a week later, they got a punch biopsy so they could look at the tissue. And so what they found was, interesting, just that process of the surgical sort of trauma from debulking really upregulated, a bunch of like Notch and Wnt signaling associated genes like patched and HEY2 and, other genes. But what was really impressive was the clinical response in these patients. So way better than you would think. So basically 3 patients had a significant clinical response. 1 was lost to follow up like a typical locally advanced basal cell patient. And then about a year later, 1 of the patients needed surgical intervention. But, we think about I think we traditionally think maybe I'll give them Vismodegib, I'll shrink down that tumor, then I'll do some surgery. But this actually suggested that it might make sense to debulk it, then put them on medication, and then bring them back and think about doing surgery.
And again, the idea is that the debulking causes the tumor to express stuff that makes it more responsive to the chemo. That's the idea.
Yes. Yeah. So it actually makes it more likely to respond than if you didn't do the surgical debulking. I think we still need more data on this, but, and how much surgical debulking do you need to do? Can you ED and C? But I like the idea of, sort of this idea of sensitizing the tumor with something that's relatively straightforward.
Yeah, I always thought sensitizing would be like a Miquimod or, the T-VEC stuff that we were talking about. You just go in there and just shave it all down, right?
Right.
Part of what I wondered here is when they debulk this, how did they get it to stop bleeding? Like with that, I guess
lots
that new
of pottery, lots of aluminum chloride.
The patients all have Alzheimer's now, but it's okay.
Exactly.
They get their BCCs are better.
I had a BCC.
Quality of life. Their BCC specific quality of life is great.
Yeah.
We're all going to get dementia whenever whenever we're 55, and
we deserve it.
we deserve it now.
Exactly.
All right.
All right, Patton, what do you? So the takeaway there, unlike one of our prior episodes where we decided that a curettage followed by a Miquimod, not Derms on drugs approved, does look like pre-Vismodegib debulking, provisionally approved. Provisionally approved.
Awaiting a study of greater than 4 patients.
You know
Yes.
what? With RFK having gotten approved, we might be the new FDA. We could just
For all of dermatology.
for all of derm, we could be the new FDA. Approved, nope. Next.
All right.
All right, Pat.
My first 6-pack was a pre-proof article from the November JAD of last year titled COVID-19 infection is associated with an elevated risk for autoimmune blistering diseases, while COVID-19 vaccination decreases the risk. A large-scale population-based cohort study of 112 million individuals. Wordy title. It's by Kerman et al. In the intro, the authors refer to a meta-analysis from 2024 suggesting COVID vaccine could be associated with new onset or exacerbation of AIBD, autoimmune blistering diseases. So what do we tell our patients? I had patients with new onset BP after getting COVID vaccine, and they would say, well, will the booster flare my BP or not? And I'd be like, maybe. And they'd be like, maybe it will or maybe it won't. And I'd be like, yeah. So I needed a better answer than that, believe it or not. It was a retrospective cohort study that used Trinetic software to study millions of patients in the United States. So starting date of January 2020 up through, I think, like May/June of 2024. 3 groups of patients diagnosed with COVID, those who received the COVID vaccine, and control patients. So just had a health encounter without any documented history of COVID-19 or vaccination within 6 months of the index date. They then performed propensity score matching, came up with 3 comparisons. So thought was, right, COVID-19 infection, it's going to be worse than controls. You get an infection, your immune system gets all fired up. If this is getting too scientifically technical, I apologize. You get AIBD as a result, right? And that's what the first forest graph shows, figure 2A. Patients diagnosed with COVID-19, 50% more likely to develop an AIBD as a result. Stronger association for pemphigus compared to with BP. Hazard ratio for pemphigus was really high. Hazard ratio for BP was lower, but it was still statistically significant. Top 3 plots, primary analysis. Authors did a bunch of sensitivity analyses. I'm not going to get into that just for sake of time. The next forest plot is COVID infection versus vaccination. That's figure 2C. Overall hazard ratio of 3.13, higher hazard ratio for pemphigus, really high, like 5.5. So 5.5 hazard ratio of the infection versus vaccination of giving you an AIBD, right? So why did I skip over figure 2B? Because it's the dramatic effect. This is the most exciting part of the paper, right? Like I said, I don't get out much. So figure 2B, COVID vaccine versus controls. Risk of developing AIBD was almost halved by getting the vaccine compared to control patients. And that was surprising to me. You would think, between a control group and the vaccine's going to ramp up your immune system a little bit. And it's probably going to be a higher risk of AIBD in those patients. And the opposite was true. It was mostly the result of pemphigus because the hazard ratio for BP was numerically lower in the vaccinated patients, but it wasn't significant. So if patients are asking about COVID vaccine, will it increase my risk? You can tell patients we have one study, and it showed that with a particular condition, vaccination actually appeared to be protective. And so take that, RFK, vaccine protected.
So,
what do you think?
Wait, first, what is extended PSM? That's one of the things in the...
So you propensity score match because you say, okay, I need somebody who's white, who's the same age, same ethnicity, same age, few comorbidities. I think their first PSM was nicotine use, things like that. They just extended it. Liver disease, chronic fatigue. Yeah.
So they were better matched than normal patients.
Yeah, matched them for more comorbidities.
This is it's mechanistically really hard to think of how this, and yeah, I know you mentioned this already, but it's hard to think of how this is possible. It just
Except the vaccine is, so I don't know that with Trinetics you're capturing every COVID positive case.
I think that, right? I think that explains it, right? These aren't controls in the sense of didn't ever have COVID, right? They never saw their doctor about COVID. They never took a COVID test. But I mean,
In the
everybody got
hospital. They
COVID.
could have, yeah, they could have taken it at home and they
Right.
just, yeah.
But still, even if you think about that, you're comparing. So that group of patients, those control patients would be, okay, got COVID, but really weren't that sick. So basically didn't have like significant immune activation. Whereas some people got pretty sick getting the vaccine.
and again, remind me, was it that COVID compared with vaccination? Which one was COVID was worse than vaccinate? Gave you
COVID
more
was
a
worse
higher risk.
for pemphigus. It had that 5.5 hazard ratio. I mean, COVID was way worse, especially for pemphigus, but it was worse for BP as well.
So anyway, it goes back to the answer we can always give. Why did I get this? It must have been a virus. Your immune system responded to a virus and it just got overworked and the whole thing. So it confirms for us we can just continue to use the virus excuse for everything.
Makes it easy.
So Ferris, I think of you as our psoriasis expert. As the dermatitis guy, I saw tons of people who believed that their dermatitis got worse either after COVID or a COVID vaccine. I don't know. Like I would always, I always agree because I was like, oh, you know your body better than me. You think the timing was right? Sure, I could imagine that. Did you feel like you saw that with psoriasis?
Not as much. Everybody just wanted to get an excuse to work from home because they were on a biologic. That was my entire COVID life as the psoriasis person.
Would you give out I'll give an excuse for almost anything because
I know you will.
Yeah, it's generally
I'm not
easier.
that nice. Haven't you figured that out? No.
It's true. It's true. I will agree with that. All right. So let's go on to my first article. So this one was just fascinating to me. So, right, diet and living environment as novel etiological factors for melasma results from a retrospective case control study of 150 Chinese patients. First author was last name Shi, and the things that jumped out at me here. So they looked at a lot of different aspects, and some of them were a little bit odd, like you remodeled your house, you didn't remodel your house, like whatever. I kind of weeded those ones out as it's hard for me to come up with any plausible explanation. But the things that were really interesting. So if you had an abnormal menstrual cycle, you were more likely to have melasma. Okay, fine. If you had a previous sunburn or exposure to sun 2 hours a day, you were more likely to have melasma. Okay, fine. Regular sunscreen user was more likely to have melasma. Now, that's one that I think is probably reverse causation, where people notice, maybe they're getting some pigmentation or something, so they start using lots of sunscreen cream. It's hard for me to buy that one. But the one that was most interesting, well, I'm going to throw in one more that just kind of, so cystic breast hyperplasia, so which I think of as a hyperestrogenic state. Sure, we know estrogen is melanocyte responsive, but alcohol intake. Now, the number of people who were significant alcohol consumers was relatively low in the study, but the relative risk of melasma for people who consumed meaningful amounts of alcohol was 20-fold higher. And so it does now, whenever I see a patient who's got melasma, I am going to, ask them if they consume alcohol, and I'm going to recommend to them if they do drink, and I'm not even talking like excessive drinkers, I'm just talking they drink. I'm going to recommend to them that they, cut that out as much as possible. Because again, mechanistically, I can, alcohol has a lot of effects. I can imagine that, it increases blood flow to your skin, and that increases heat to your skin, and that increases pigmentation, something like that.
A lot of imagining.
A lot of imagining.
Maybe they're drinking their alcohol outside in the sun while remodeling their house. Maybe confounded.
Which is not safe. You should not be drinking
Exactly.
any
Do that.
Yeah, don't do that.
Or while getting a mammogram to find your cystic hyperplasia. Who knows?
So there were a few things that protected. So seborrheic dermatitis patients were less likely to have melasma. People who drank soft drinks, less likely to have melasma. Let's see here.
I
And
thought
then
that was a vitamin C effect, right? Didn't they say a lot of the soft drinks have the vitamin C?
well, so I'm going with caffeine because
Okay.
coffee intake also reduced your
Okay.
risk of melasma.
Okay.
Interesting.
So I'm going with,
Don't
but
people use caffeine in like skin brightening
oh yeah,
topical things too?
I didn't even think about that. Yes.
I thought
So
the moving to a new place was kind of interesting because they said in the paper when you move, most of the time you're moving like to a nicer place, or you're moving like out of the city into a more sort of like not in the city. And they felt that maybe the higher pollution and things like that in the city affected. It was an interesting paper. I mean, I the
Yeah.
alcohol, interesting. Maybe I'll mention it. I'll probably mention it.
right, because I was looking for like what can I talk to people about? Because I'm
Yeah.
not going to be like, well, did you move? Oh, you shouldn't have. Like, what?
Did you remodel your house?
Yeah. Go
Stop.
back. Go back to your old place.
So, but the alcohol thing's useful, and then the caffeine intake, I can buy that. We know that coffee has a lot of, there's a lot of data that coffee is beneficial for cancer, decrease cancer risk, decrease dementia. I can't remember, decrease something. So it may, coffee intake might be good. But all right, that was our primary takeaway from there. So less alcohol, maybe more coffee for your melasma patients. And let's move on to our next study here, Dr. Ferris.
All right, so this is the impact of antibiotic therapy in psoriasis patients with active streptococcal infection, a prospective study. So this is the Journal of Dermatology, Bon Clanny et al. So this was, we all
Wait,
have
wait,
been
wait.
taught
It was
what?
it was Bonciani. That's an I, not an
Okay,
L.
fine.
It's
Okay, thank
not,
you for
not
correcting me.
Bonclani. Bonciani.
Okay. Oh, Bonciani. Okay. I was misreading it. Okay. So we all are taught, strep infection is associated with psoriasis or gut-tape psoriasis or psoriasis flares. So they kind of tried to answer that question, but they had 155 psoriasis patients, and then they had, sex-matched dermatology patients who didn't have psoriasis at about the same period. And what they did was they came in, they did a throat swab to look for strep, and then they checked ASO titers. And so the patients who had strep infection with psoriasis received both topical treatment, which was basically betamethasone calcipotriol, and an oral antibiotic, which was like amoxicillin or clarithromycin or clindamycin. And the people who didn't have strep, they just got the topical. So they included strep infection as positive ASO or a positive throat swab. So these are not like people coming in with terrible sore throats. It's sort of just like, did we find evidence of this? So, I think the thing that was interesting was 25% of patients with psoriasis had a positive culture. Half of them were ASO positive, whereas only about 13% of healthy controls were positive for that. So more evidence of strep in the throat or, positive ASOs in psoriasis patients. But they really did not see they didn't see more improvement with like antibiotics didn't make these patients do better. Now, they didn't have a control group. They decided it would have been unethical in an asymptomatic person who they happened to swab and have a positive test to not treat them. So they didn't have a control. Like, okay, this group gets antibiotics, this one didn't. So, there was maybe the patients who got antibiotics, their PASI scores were a little bit lower, didn't reach statistical significance. I don't feel like this really gave me a whole lot of answers, but interesting. I thought the most interesting thing was just higher prevalence of positive throat cultures.
And you guys, neither one of you does sort of empiric amoxicillin or anything else in your gut-tape psoriasis patients?
I don't.
No.
Didn't Cress in English teach us to? I feel like that's what we did in residency.
I don't. I mean, Cress maybe. I don't think English like
Yeah,
if you
you're right.
weren't symptomatic, but maybe I'm misremembering.
I don't remember
It was
doing
very
that.
traumatic training under him.
No,
There was a
no way.
lot.
I'm putting in a plug. The two greatest dermatology educators in the history of dermatology were Joe English and Doug Kress.
That's right.
They're
We
amazing.
wouldn't be here. We wouldn't be there.
We
We wouldn't
wouldn't
be
if it
here
weren't for them
without
too.
Right.
That
them.
is true.
Any normal people would have rejected all three of us. So we're very lucky.
I'll still never forget that day when I found out, my God, there's a DO coming to do residency with me. Like, what? Where has my life gone? And it turns
Yeah.
out Patton's
You've just lost your whole DO audience. Thanks, Matt.
No, because it's a happy story in the end. I
right.
converted him.
It was a stereotyping that was, I learned my lesson. Like,
And he's the
Patton's
smartest of the three of us.
right.
Oh,
Right.
best
Patton's a good
looking.
So
doctor.
yeah, but
Best
no,
looking.
interesting the strep thing. There's some data that like tonsillectomy may improve psoriasis, so there might be something there. I just think this wasn't the way to get at it. But
I
stay
forgot
tuned.
about that. I've had some old dermatologists tell me that they had patients back in the day when we didn't have like amazing drugs, who they really saw tonsillectomies. Not everybody, they didn't like tell their patients go get your tonsils out, but they had their experience over a long time was that a tonsillectomy made a substantial number of psoriasis patients psoriasis much easier to treat. Uh, yeah, which is believable. It's believable. Okay. Let's move on to our next patient here, our next study. So, Dr. Patton, why don't you go ahead?
Yeah, second six pack was January edition of Seminars in Arthritis and Rheumatism titled Use of Biologic Drug in the Treatment of Localized Scleroderma and Systemic Sclerosis in Children, a Scoping Review by Center et al. Why did I pick this? Because I do manage linear scleroderma in adults from time to time, not kids, but I figured it would be relevant. My treatment algorithm combines steroids and methotrexate, maybe add mycophenolate somewhere down the line. So I saw the title and I'm like, biologics, like, am I this, prednisone methotrexate kind of old fashioned? Am I missing out? Like, are there biologics I need to start thinking of? This is the age of biologics. Even though the article discusses both localized scleroderma and systemic sclerosis, I was just going to focus on the linear scleroderma part. Systemic sclerosis often managed by rheum. So it was a review that was conducted on 29 articles. Text goes through a bunch of numbers and the tables are hard to understand. They were for me. I'm not that smart. Almost all the patients were on or had been on corticosteroids and methotrexate, and a lot of the patients also tried mycophenolate. So it still looks like those are first and second line agents for localized scleroderma. Main points, there was a visual abstract. Most preferred biologic was abatacept, 55.2 of patients. Abatacept is Orencia. Second most
What's a
preferred drug.
base? What's it do? Do you know what its thing is?
Abatacept it's a CTLA4 protein hooked up with IgG. So the CTLA4 protein binds to CD80 and 86 on the antigen presenting cell, basically not letting the antigen presenting cell interact with the T cell and activating it.
Blocks co-stimulation.
Thank you. I could have said it blocks co-stimulation.
So it's like the opposite of the cancer chemotherapy drugs.
Yes.
Yep.
Okay. All right. Got it.
All right. Second most preferred drug was tocilizumab. That is an anti-IL-6 antibody. That was used in 48.3% of localized scleroderma patients. Main indication for using biologics was progressive skin disease, so it was kind of derm relevant. That's why they did it most frequently, is because they were on some of those other medications and the skin disease was getting worse. They list these improvement rates. Abatacept 92.9%, tocilizumab 77.4%, but like the number was really confusing for abatacept. The response rate was only reported on 33.3% of patients, so close to 70% didn't have data on whether they improved or not. It's really hard to say that 92.9, like, oh my gosh, that works awesome. But they didn't have data on 70% of the patients that were, in this review. So tocilizumab data was available for close to 90% of the patients. So even though the improvement rate was lower, that number might be a little bit more reliable. I don't know how helpful this article was. It reassured me steroids and methotrexate probably still the way to go. Mycophenolate, if you're not getting that response, maybe consider abatacept or tocilizumab, but I've never given those drugs, so I don't know how easy it would be. They're not FDA approved. They have both been evaluated in controlled trials. There was a phase 2 multi-center randomized blah, 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 a Betacept published in 2020. Primary endpoint of an improved skin score wasn't reached, or it didn't reach statistical significance. Let me say that right. And then there was a phase 3 trial, tocilizumab, also published in 2020. Primary skin fibrosis endpoint wasn't met either. So I don't know. What do you guys think?
Well, the adult ones you're treating, are they in cutisab, or are they like over a joint, or it could be any of it?
The last 2 that I treated, and like I said, I don't treat a ton of this, but it was linear over a joint, elbow, hand, affecting range of motion. Yeah.
Okay.
I'm mostly sending these patients to rheumatology when they're at that point of like needing more than methotrexate. But
Rheum it can be weird though, right? I mean, the last one I saw had seen rheum, but rheums have their specialties. So they saw like maybe it was a DM specialty rheum person and said, linear scleroderma is derm, like go and see them.
Yeah, but I guess I'm not given a Betacept or tocilizumab.
No,
I guess that's yeah. Like at that point, I'd be working with them. But interesting. Maybe I'll think about it more.
Yeah.
So, Pat, I got to ask, there was this beautiful cord diagram.
Yeah, I know.
It's gorgeous, but I can't make heads nor tails of it.
It was really about indications. And so it's easier if you go down to like infliximab, where there was like one patient on infliximab, or maybe it was rituximab, and the cords go out as why was that person given infliximab? Well, there's 3 little cords to 3 different of indications, progressive skin disease, maybe it was pulmonary. So it was basically whatever drug it was being attached to the indication for that particular drug. Honestly, I think that's why I picked the paper. That thing was, I want to get that on a t-shirt, and then I would wear it, and people would come up to me and ask me about my cool t-shirt.
That might be what happens. Yeah.
All right. So Patton easily dazzled by pretty colors. That's the takeaway. All right. So let's get to our last paper of the 6-pack. So this one was mine. And as regular listeners are probably starting to figure out, we are big proponents on Derms on Drugs of oral roflumilast. So this was a real-world 24-week prospective cohort study. And really, there are a couple of things that were useful here. So first, how good is this drug? So oral roflumilast, for anybody, again, who doesn't know about it, think Otezla, but free and more effective, but also probably a little more GI side effects, is the way that I think about it. But mechanistically, it's identical. It's just higher potency. It is a PDE4 inhibitor, and it went generic about a year or 2 ago. And so it's about $6 a month if you get it through Mark Cuban's Cost Plus Pharmacy. No labs, no immunosuppression. So this was people who went on oral roflumilast. And how many of them, the key things here were how many got PASI 75 and how many got PASI 90. So if we look at the PASI 75, it was over 50% of people. So it was between 50% and so between half and 2/3 got PASI 75. So if we looked at it as observed, it was modified NRI, basically as observed. It was 2/3. If we looked at it as non-responder imputation, intent to treat analysis, it was half. And for PASI 90, it was somewhere between 1/3 and 1/2. So depending on how you looked at the stats. So a good drug, they actually had better numbers. There was a randomized double-blind study, or at least a randomized blinded study, where they looked at intramuscular methotrexate versus roflumilast, and they actually got more like 75% of people to PASI 75 and about half to PASI 90. So it just goes back to another thing. This is a really useful drug. If your patient has been on a biologic before, they're probably not going to be happy on it because it's slow, does give you some GI upset, and doesn't work as well. But it's incredibly inexpensive, no immunosuppression, a very safe drug. And so using it for psoriasis gives us, the main reason I think it's interesting is it gives us an idea of how effective it is. the main places I'm using it are more lichen planus, granulomannulare, lichen planopilaris, stuff like that where we don't have better drugs. And then occasionally in psoriasis, whenever I can't get a better drug covered, and anything that either of you kind of wanted to add about this. The main reason I wanted to do it was just it gives us again more of an idea of how effective this drug is as a general idea of how well is it going to work for LP or whatever.
I like it. People say, "Oh, I like to add Otezla to biologics." Like I can never get that covered, right? So I will sometimes do this in combination with a biologic. I also thought, baseline, there are 58 patients. At week 12, there were still 52 in there. That's not that bad of a dropout rate for something that does have GI issues. So I thought it was interesting. I like having it in the toolbox.
Yep.
Yeah, I love having roflumilast. I think we talked about that. For me, it is the new methotrexate. We use methotrexate for a bunch of stuff, and it's a safe medication. I don't want to overblow the side effects of methotrexate, but you do have to do monitoring, and you have to go through all those potential side effects. Roflumilast, it's just, I love it. It's my methotrexate.
There's data that it reduces cardiovascular morbidity and mortality in COPD patients. And I think I don't know if I've mentioned this before, but there's one study where they gave it to young, healthy people, and it made them smarter.
Yeah, if you were smart enough, you would remember that you told us that.
Clearly, you're not taking enough.
I need to up my dose. It might help me. I have a friend who is on it. He had this crazy gingival plasmacytosis. So friable red gums, bleeding anytime he ate anything, trouble brushing his teeth because it was so bad. And I was like, oh my God, you got gingival hyperplasia. He went to see a good oral pathologist, oral plasmacytosis, which he's like, I've seen 6 cases ever. This is incredibly rare. I wish I could put him on Otezla. I think it would work. And I was like, oh, well, but I can't get it covered. I was, try the roflumilast. Worked amazingly. Right. But he's a healthy, 53-year-old guy. He lost 40 pounds because it was just the GI, the nausea, the effects on going to the bathroom, the whole thing. It was miserable.
Wow.
So yeah, it was interesting having a friend on it rather than a patient, kind of hearing what he had to say. Yeah. Well, I want to thank everybody for joining us this week. Hopefully you found the articles in our 6-pack interesting and that you will find them useful in your day-to-day practice. If you've got questions, if you've got comments, ideas for topics we should cover on the show, shoot us an email at questions@dermsondrugs.com. Again, that's questions@dermsondrugs.com. I do really want to recommend, if you haven't been there, go check out the Scholars in Medicine platform. If you just Google Scholars in Medicine, you will find it. They've got 80 hours of really well done derm lectures, a lot of content across the board in terms of meetings, abstracts, new stuff out of the journals. Just a fantastic educational platform that is at no cost to us as derms, and especially send medical students, people new to derm, MAs, people, like I said, new into derm. Just a great platform. But all right, I hope you learned a few things. Hope you laughed once or twice. And mostly, I hope you're planning to join us next week. Till then, I'm Matt Zyrus.
I'm Tim Patton.
I'm Laura Ferris, and we are Derms on Drugs.